Welcome to today's session. Our first speaker is Shaun Kinghorn. Shaun joined, as he explains, the VTE Club in 2011 following a pulmonary embolism and has been ever since a fantastic patient advocate. Thrombosis UK have been very fortunate to welcome Shaun as one of our trustees several years ago, and since he's been a huge support to all of the team and participated in many events. So without any further delay, I'd like to pass over to Shaun. Thank you.
Thanks very much indeed, Jo. And I guess I'm absolutely delighted to be here today to talk about this really important issue in terms of that recovery journey from either DVT or pulmonary embolism. I'm also looking forward to the section at the end to see what sort of questions that you've got that might help you make the most of your consultations. In my brief presentation, I plan to touch on two areas. It's offer a very thumbnail sketch of my recovery journey, so it offers some context on some of the consultations I had with healthcare professionals. And then the second part is to offer some tips and thoughts and reflections on my consultation journeys. And can I say that I think overall, I'm extremely appreciative of the consultations I've had with a wide variety of healthcare professionals. And I recognize through time that what I did and said could actually make a difference in terms of the quality of those consultations. So can we have the first slide, please, Jo? As I mentioned, this is really a thumbnail sketch of, I guess, 10 years of on that VTE journey. And it started in A&E back in 2010. I was at home and basically I went blue and pale in a very collapsed state, was taken to A&E. My wife's an A&E nurse and was admitted to emergency medicine unit in my local district general hospital. I don't remember much about the first 24, 48 hours, but apparently I had quite significant clot burden. And my consultant said to me, if I hadn't come in within the time I did, another hour could have been quite significant and I may not have survived. My progress was incredibly slow. I'm not saying my experience is exactly the same as yours, but fundamentally, I need to be referred on to pulmonary hypertension service by my GP and had a whole range of investigations, which I'll not go to in detail. But the bottom line was really after 2 to 3 years of investigations, it was evident that I was left with some residual problems in terms of lung capacity. And I needed assistance with breathing at night with my CPAP mask. CPAP has become, I guess, quite noticeable in terms of the COVID crisis, being an important part of the treatment program. And so basically my first 3 years were horrible, very difficult. And I decided to go into semi-retirement at that point to invest time on improving my health and well-being. I was referred for an exercise program, and that was a turning point. And I realized a lot of my progress was simply because I'd become deconditioned with a previous history of swimming, cycling and running. My body just needed to be retuned. I've had a few bumps in the road since then, but fundamentally I'm well and very fit. And I think it was 2 years ago, Jo, I did a 10K run for Thrombosis UK, but I'll not be bidding for a place for Tokyo this year. I'm a long-term, lifelong Warfarin user, and my target now is 2.5 to 3.5, and I'm now self-testing thanks to the support of the Thrombosis UK team. Next slide, please. As I mentioned before, those first 4 years were incredibly different and difficult. And one day I must have been bored or something like that, but actually went through my diary and counted how many appointments and consultations that I had. And they totaled over 350, and not all were consultations. Some were for blood tests, for scans, heart catheters, etc. And some of these were self-referrals. I referred myself for physiotherapy. After the end of year one, had some terrible neck pain and upper chest pain. I also referred myself from token therapies, 4-month PE, because I recognized myself, I was incredibly anxious. And I wanted to sort out what was in my mind and what was the result of the PE. and I quickly realised that the PE had left some residual symptoms. I've asterisked some of those consultations or staff who I found really, really helpful. And it was something about the manner. It was about the compassion. It was their willingness to ask me questions and challenge my thinking about what had happened. But it was also about they were so open to receiving the questions that kept me awake at night, that were troubling me or a worry or a concern. As you can see, the number of consultations and staff who are actually offering ongoing consultations and support for me have changed. I still receive input from my GP, who's been excellent, an ENT consultant just to keep an eye on this parotid tumour, and also a respiratory and sleep medicine. And I still have the support of the anticoagulation clinic. Next slide, please, Joe. I'd just like to share briefly two experiences. And the reason I share them is not to illustrate my perspective, but it's about how my thinking and involvement in my consultations changed. And this first comment relates to approximately 18 months into my VTE journey. And I was just about to be discharged by the pulmonary hypertension consultant, who had confirmed that he didn't think I had this complication of CTPH and wouldn't need to be referred down to the surgical team down in Cambridge. I was exhausted at that time, and my wife was at the consultation with us, and she just simply said, okay, I realise that you want to discharge him, but you do realise he can't lie flat without getting breathless, and his oxygen saturations were low. And I look back, and that was a really defining moment, because that led to another referral, which found that I needed support overnight from CPAP because my oxygen level was low. And as a result, the consultant decided to watch and wait for another 18 months in terms of my care. So take-home message there is it's good to have somebody with you if you're feeling really unwell at the start of the VTE journey, who hears things that you can't hear when you're feeling unwell. And I think that second comment relates to, as time progresses and you're starting to feel better, is that I started to become interested in my own safety and recognize that I had a contribution to make with regard to maintaining my safety. So ask challenging questions, particularly when I was going to have surgery for the first time for 2 hernia repairs. Next slide, please, Joe. So in terms of looking back, and it's very difficult to capture 10 years, and I'll make sure that I won't go on for another 30, 40 minutes. I'll keep this brief. But I found there were certain things that I thought about that may be of help or of interest to you, or maybe in the chat you've got other tips that you found helpful at consultations. And in terms of the hard years, I started to keep a diary of symptoms. And the reason was not about obsession, was simply because I found it difficult to articulate to the consultants and the nurse specialists and the respiratory consultants exactly what was happening to us. So I basically kept a diary, and this is my 2010 diary. I don't know if you can see it, but I just flashed it up, and just at the end of the day, actually write down what symptoms were prevalent. And as I used that when I went to consultations to write a brief summary, literally half a page of A4, and said, these are the problems and concerns I've got. These are the things I need help with. And can I say that the healthcare professionals were brilliant? At first, I was reticent to do this, but I could see, literally, they didn't have to spend 10 minutes asking me questions. They got a sense of where I was at that time. When things didn't go well, or I was struggling, I needed to move appointments, I rang the consultant secretaries or the nurse specialists to bridge there. In terms of getting better, my mindset changed. I wanted to play a more active role in my progression and improvement. So I started asking a lot more questions. And you can see these are some of the questions I've noted there. And then finally, the new normal now is my VTE journey hasn't finished. It's still there. I'm still on long-term warfarin. I've still got questions. There are new things happening around us, new treatments, new insights. And for me now, my consultations are about, is there anything new on the horizon? These are my preferences. This wouldn't work for me. And it's about staying safe. Next slide, please, Joe. So in summary, really, in terms of making the most of your VTE consultation for healthcare professionals, you will probably have some better ideas than I, but before the appointment, the more prepared I was for an appointment, I got more out of the consultation, and I drew more from the expertise of those staff in those consultations. So once again, I was keeping the diary, and also the mindset is, what can I do to get the most of this? During the appointment, and I think Joe's already alluded to this, is about in the checklist, is about your questions, and also having an open mind in terms of the information that we receive from the healthcare professionals. It's also worth writing down what was said. And certainly following the appointment, I started actually put my letters in order that I can have a cohesive picture of my recovery journey based on what the nurse specialists and also the consultants and medical staff had to say about my progress. So in terms of just 3 tips, think about before the appointment, what you're going to say and do during the appointment, and what follow-up are you going to make. Next slide, please, Joe. So in conclusion, my summary is that really consultations are a really important part of our progression and recovery journey. It helped me understand what had happened. It helped me understand my treatment. It also allowed me to reflect on quality of life issues and to share them with staff. It offers an opportunity for me to ask questions and share insights. But also consultations are scary because there are times I had bad news with regard to my future at different times, but also there was sort of hope and relief. The outcomes of consultations did help me make changes in my life, and also challenge my ideas and perspectives on what had happened to me and the management of my anticoagulation. I think really important as well, and thanks to the staff here, it helped me get through the hard spells in that journey. And I think it would be fair to say that generally consultations between patient and healthcare professional are a learning journey for both. And here's 2 slides here. That's my 2 daughters and son, and that's on the top of Skiddaw. I would have never imagined in the first year of my VT recovery that I would be in the top of Skiddaw. I'll not tell you how long it took, but it was just lovely to be on the top. So just to say thanks for listening, and I hope you enjoy the rest of the presentations.
Thank you, Shaun. That was really insightful. And I think, one of the points you raised that for me sort of rang bells was the people around you notice things. Talk to them, your family, who you're close to, because they can also raise some really important points. I think you're on mute. But yeah. Okay, well, thank you very much, Shaun. That's brilliant. Really enjoyable and very, very helpful. We move now to Christina Sleep. Christina is a thromboprophylaxis clinical nurse specialist. I think she's based at Addenbrooke's, but across the Cambridge University Hospital Trust. And Tina's going to continue talking about what to expect in your follow-up appointment after diagnosis. So I'm just going to share Tina's slides now, and then I will take a few moments for my screen to get ready on this, and I will be able to do this. Sorry, Tina.
Okay. Lovely, thank you, Joe. Yes, my name's Tina and I'm an anticoagulant nurse here at Addenbrooke's Hospital, as well as other various other roles as well. But I'm going to talk today about what happens, as Joe said, at your anticoagulant counselling appointment, which here in Cambridge would normally happen about 7 to 10 days after being diagnosed with a VTE and starting on an anticoagulation. Next slide, please, Joe. So I like to start my clinic appointments with a how are you? Just a general basic question of sort of to break the ice and see how my patient is, see how they're feeling. Some are really positive and feeling much better on their anticoagulant. some are not so happy and still having lots of issues, and it really sets a tone for the consultation, and it helps me know what the patient's priorities are, what their concerns are, and really what we need to concentrate on in that consultation. We have 20 minutes for the consultation here, so it's a fairly reasonable time. So it's really good to be able to talk, see how the patient's feeling, see how they're getting on, and then I would explain the purpose of the appointment and what the set out of the appointment is going to be, whether they're going to need some bloods or further tests afterwards, just so they know what they're expecting, and there's no surprises for them. Next slide, please, Joe. Different patients have different priorities. Personally, I love a patient that comes with a list of questions. The longer the list, the better it is with the consultation. And I know that that patient's going to get the most out of that consultation. So brilliant. Google, talk to your friends at the golf club, make a list of all the questions you can possibly think. It doesn't matter how silly you think they are, how important they are to you or not important you think they might be. Ask. If you don't ask, I don't know that that's what's bothering you. So please bring a list. I have to say, when it gets to sort of page 5, I slightly get concerned, but you know, a couple of pages of questions is always really good. And these are the most common questions, obviously, that we get is, why did I get a blood clot? What is this anticoagulant? Do I need to take it every day? Is it going to have a major impact on my life? How long am I going to have to take it for? And how should I take it? Is there a special way of taking it? And all these questions are completely relevant, and absolutely we need to concentrate on and cover these in our consultation. I'd like to think that I normally will say, look, I've got things I have to say in this consultation. Please let me say my bit, and then we will ask questions and go through it at the end. And that's kind of how I like to lead the consultations. Quite often what I say, we'll answer the questions as we go, and otherwise I kind of forget where I am sometimes in the consultation, but it depends. Everybody's different, and I like to make consultations different to suit individual needs, so we can tailor it to whatever the patient wants and how they want to lead the consultation at that time. Next slide, please. So one of the biggest questions is why have I got this clot? Why me? What have I done to deserve getting a clot? And quite often I have to explain, and it's quite a difficult one to explain, is we don't really know why you've had this clot. Quite often it's completely out of the blue, and that was what we would call an unprovoked clot and would need some further investigations. But sometimes we never fully understand why the patient has had a clot. Sometimes it's really obvious and there'd be a really clear reason. Maybe they've been in hospital for a couple of weeks, had a hip replacement, been really immobile, been unwell. Obviously, COVID has been an issue recently. And maybe a combination of risk factors have gathered together to cause them to have a clot. And we'd call those provoking factors, and there would be a provoked blood clot, which I think is sometimes easier for patients to understand if they've got a good reason and they know why they've got the clot. I think it's quite often easier to accept it than not really knowing why you've got one and why this come completely out of the blue as a surprise. So I like to explain why you've got a clot and whether we can understand why or not. Next slide, please, Joe. I then go on to try and explain what is an anticoagulant medication. The fact that it's slowing down the time that it takes your blood to clot. It's there to prevent harmful blood clots, but it doesn't really get rid of the clot that you've got. It's stabilizing that clot, stopping it getting any bigger, stopping it traveling anywhere else. And the blood clots that you've got should disappear over time. I also like to make sure that everybody knows exactly what all these terms are, because I feel like when you're initially diagnosed, you quite often sort of have this sort of hearing loss and you're not really taking everything in. So I explain what a VTE, a venous thromboembolism, is, and it's a term that covers 2 conditions, one being a deep vein thrombosis, also known as a DVT, which is when a blood clot blocks a blood vessel, usually in the deep veins of the leg. And also it covers the term for a pulmonary embolism, or a PE, which is usually when a part of a blood clot from a DVT, so in the leg, travels to the lung, resulting in a blood clot in the lung, so a PE. I like to make sure they understand the terminology that we're using, because as we all know, in medicine, there's so many different terms, it gets very confusing, and it's like, well, have I got a VTE? Have I got a DVT? Was it a PE? It's all these different terms, and we need to try and understand those as well, and so get some clarity from the consultation. Once we've gone through that, I then obviously I explain that we're treating their clot with an anticoagulant to stabilize it. And once this is explained, it's important for me to move on to the side effects of anticoagulation. So next slide, please, Jo. Thank you. It's really important that patients on an anticoagulant know exactly what to look for their own safety. And there are many common side effects, which can include indigestion, minor bruising and minor bleeding. And those all need to be monitoring and patients need to be aware of, but quite often don't need any further medical intervention. But if they are persistent and causing concern, then obviously consult a GP or give your anticoag clinic a ring and we can advise you what to do next. The more serious side effects that we need to make sure patients are aware of that need medical advice immediately would be the ones as on the slide. So the vomiting or coughing up blood, prolonged nosebleeds, blood in your urine or when you open your bowels, severe sudden headaches, spontaneous or severe bruising, dizziness or weakness, any major trauma or any bleeding that you can't stop. It goes to say most of those we would expect you to phone 111 or come into A&E to get checked out. And it's really important that patients understand that, not to alarm them and cause massive concern, but it's important that they're aware that this could happen and this is what they would need to do if it does happen. But it's sort of worst case scenario, so hopefully they won't experience any of that. Next slide, please. Thank you. So what can affect the anticoagulation? We need to make sure patients are aware of that as well. Obviously the DOACs, which is the shortened version of the direct oral anticoagulants, which are apixaban, dabigatran, edoxaban and rivaroxaban. There's not many interactions with those, so we don't need to worry too much, but just make sure that your GP or a pharmacist, if you're buying medication or being prescribed, knows that you're on the anticoagulant. And also read the instructions or talk to your anticoag service about how to take it. Some of them need to be taken with food, some of them need to be kept in their blister pack before taking, some of them can be crushed, some of them can't be crushed. So it's just important to know exactly how to take it so that you get the best effect from it. Warfarin, the most common vitamin K antagonist, is a little bit more complicated. It does interact with lots of other medications and prescription drugs and over-the-counter drugs as well. So always let your doctor and the pharmacist know. And you may well need more frequent monitoring. So when you're on warfarin as an anticoagulant, it needs regular INR blood tests to monitor the effect it's having on the clotting time of your blood. And that can change depending on diet and other drugs and alcohol and all sorts of things. So it's just worth talking to your anticoagulant service or your GP surgery, whoever's doing your INR testing, just so that you can get that tested frequently if you're changing your diet or you're on any new medication or stopping medication, because it is easily affected by lots of other things. Thank you, Jo. Next slide. One of the most burning questions we get when patients come into counselling is my lifestyle. These are the things I want to be able to do. Can I still do them? And so I thought this was like a little bit of a quiz. So in your heads at home, you can be going, oh, could I go skiing? Oh, could I go horse riding, boxing, rugby, dog walking, knitting? Definitely knitting and book reading. That's definitely, you can still do that. I think everything else needs to be done as long as you're well informed. We do, in my consultation, I do advise against contact sport. If you're on an anticoagulant, if you want to go and play rugby or go in a boxing ring, the chances are you're going to have very severe bleeding and bruising issues, and I would not recommend you doing those sporting activities. But the more middle of the road ones, like skiing, horse riding, cycling, I think as long as you are aware of the possible dangers, and that if you were in an accident, you probably need to get medical help or fairly quickly, and take all the right safety precautions of wearing a helmet, back protector, all those kind of things, then I don't see any reason why you shouldn't do it if that's what you want to do and you know what you're letting yourself in for. I'm never going to turn around and say, no, you need to sit on the sofa every day and just do knitting, because that would be pretty boring. The most interesting one I got asked once was, can I do a sponsored skydive? And that was a tricky one, because they clearly had been wanting to do it for a very, very long time. And in my head, I'm thinking, gosh, if you land really heavily or you hurt a leg or you sprain something, it's just going to be a nightmare. But they were desperate to do it. So I think I set out the dangers and what could happen. And they went and did it anyway. And they raised a lot of money for charity and they were fine. But I think as long as you know the dangers and what might happen, I think, you know the risks and make a sensible, informed choice. Next slide, please. So towards the end of the counselling appointment, we need to make sure that patients have an anticoagulant alert card, and the traditional ones are the yellow ones in the top corner there, usually used for the vitamin K antagonists like Warfarin. The other one, there's Xarelto, that's a rivaroxaban one. Most of those DOAC medications come with their own alert card now in the packaging that you'll get from the pharmacy. We do, as an anticoagulant service here, provide alternative ones or ones if you lose one. So if you've lost one or don't have one, just contact your anticoag service and I'm sure you can get another one. Also, some patients ask, is it worth having a medical alert wristband or a pendant around my neck? And I always say that's a personal choice. If you want to have one, that's absolutely fine. Why not? And there are lots available online if you want to research those. But it is really important to carry one just in case of an emergency. And it's also a reminder to show your doctor or other healthcare professionals, dentists, phlebotomists, anywhere like that, that you're on an anticoagulant. And the other thing that's really important that I stress is if you come into hospital for anything at all, get admitted for surgery or anything, make sure all your doctors know that you are on an anticoagulant, or you've had a blood clot in the past, just so that that anticoagulant will continue through your admission, or we can put you on an alternative one, maybe some injections while you have some procedures. But it's really important that that anticoagulant isn't stopped just because you're in hospital. Next slide, please, Jo. Thank you. So lastly, it's kind of what next in the counselling appointment. Obviously with the Warfarin, the vitamin K antagonist, it's a little bit more complicated because they will need regular INR blood tests for monitoring and dose adjustments. Here in Cambridge, that's through your GP surgery, and that comes into us as an anticoagulant service here in the hospital. But some GP surgeries have their own monitoring, so everywhere's different. You just need to make sure that you've got an up-to-date record book for recording your INRs and your Warfarin doses. Always take anticoagulation according to the instructions on the box, and if you're not sure, give us a ring. We're always there and happy to answer phone calls. Keep your anticoagulant in a safe place. Please don't keep it in a fridge or next to the oven. In room temperature, somewhere safe, up high, out of the reach of children is ideal. Don't run out. I get panic phone calls. I've just taken my last tablet and I haven't got any more. Please let your GP know that you need a repeat prescription a good 3 or 4 working days before you're going to run out. Some GPs take quite a while to sort it out. Lots of printed information. I know that it's difficult in a consultation to take everything in. There's a lot of information, so I always hand out written information which backs up everything I say. At the moment, obviously, lots of our consultation by telephone, so I will send a copy of a letter that I'm sending to the GP and information leaflets out to the patient so that they've got it all to have to hand, and our phone number is on all the paperwork that we send out, so patients can easily access us by telephone if they need it. And then finally, we make sure that they get a review in thrombophilia clinic if appropriate, so we may well refer them on to here. It would be Dr. Thomas for his thrombophilia clinic for about 3 months after their diagnosis. And that leads us on to him next, I think. So thank you for your time and for listening. And that's me.
Thank you very much, Tina. That was really informative. And can I you mentioned about written information. So you discuss all of this, but you also hand out written information?
Yes.
Where do you mostly source your written information from? Does the hospital produce it?
So we have our own patient information leaflets that have been written by our service in conjunction with our consultants and our pharmacist. And yes, so we have them specific for DVT or a PE or for other reasons that my patients might need to be on anticoagulants. So yes, we have specific leaflets for conditions.
Thank you. I'm sure we'll go back to that later. Please, can I remind the audience, do feel free to put a question in the Q&A or the chat, and we will come to it at the end of this. Now, it's my pleasure. I'm just going to find the slides though. Yes, it's my pleasure to now introduce Dr. Walt Thomas, who is a consultant at the same Adam Brooks Hospital, so the Cambridge University Hospital Trust, and who some of you may have already recently had connections with through some research. Well, not, it was initial research doing a focus group around patient information and patient consultations. So I think today we're really looking forward to learning more about this. So without further ado, I will pass over to Dr. Thomas. Thank you.
Thanks, Jo. We've had two great talks, and in a way they kind of illustrate the differences in priorities for what clinicians want to tell patients and for what information patients need. And I think I'll probably illustrate that tension again in this talk, but I'm going to try and pose some questions that I think are really important that everyone asks when they go to see their doctor at the kind of 3-month review, or even initially when they get their clot. So next slide, please, Jo. So these are my conflicts of interest. So these are the 4 major questions that I'm going to talk about. I think all patients need to ask what their risk of a further clot is once they've had their 6 weeks or 6 months of anticoagulation. But for the purposes of the talk, let's imagine that everyone gets an initial 3 months of anticoagulation. And I think if patients, if you want to stay on your blood thinner beyond 3 months, it's critical that your doctor or nurse or specialist talks to you about the bleeding risk every year on blood thinners. And then finally, there's so those 2 questions: what will my clot risk off blood thinners? What are my bleeding risks if I stay on blood thinners beyond 3 months? And then 2 final questions, which are, and Shaun really highlighted this, what about ongoing breathlessness? It takes some time for blood thinners to work. And so I think that 3-month review is critical to work out if there are ongoing symptoms if you've had a clot in your lungs. And then the other really kind of analogous thing is what about leg swelling? If you've had a deep vein thrombosis or clot in the leg, you may well have ongoing symptoms from that in your leg. And I think it's critical that that's discussed. Next slide, please. So I'm going to very briefly talk about these 4 themes. So all patients with a clot, for the purposes of this talk, get an initial 3 months of blood thinners or anticoagulation, and then you assess what the risk is of a further clot against bleeding risk. And we really classify clots into 3 categories. And the first of those is strongly provoked. So that would be a green light on the kind of traffic light symbols. And so these are clots that occur shortly after events such as major surgery. And that would really include something like a total hip replacement. And for that type of clot, we give 3 months worth of blood thinners. And then when we stop the blood thinners, the risk of a further clot per year is in the order of 1%. Then there's something called weakly provoked clots. And these are clots that occur when you have a kind of minor factor. So tearing a muscle, maybe a long haul, very cramped flight, maybe the combined oral contraceptive pill. And in that situation, if we stop the blood thinner after the 3 months, the risk of having another clot could be in the order of 3% per year. And the final type of clot is the one that comes completely out of the blue, and we don't really know what causes that, which is quite intellectually difficult for a lot of our patients. But the risk of a further clot, if we stop the blood thinners, is in the order of maybe 5% per year. And these are really important questions for you to ask, because this can shape your approach and attitudes to whether you want to stay on blood thinners or not, and what your kind of attitude to risk is. So next slide, please. So the key thing that we need to do is put the patient's priorities at the heart of this, and their priorities are key. There are some strategies to help determine in a bit more of a nuanced way than that traffic light symbol, the the risk for further clot, and you can discuss that with your specialist. Sometimes we do blood tests to help with that kind of that strategy to determine high or low risk, and that's something you really need to pick apart with your specialist in clinic. The other thing to determine is, where does your clot occur? So we know that clots that occur in the calf vein, so that's right at the bottom of the leg below the knee, have a low risk of coming back, so it's less than 2% per year. And if they do come back, it tends to be in the same place. So although a calf vein clot is in no way nice, it doesn't tend to be life-threatening. So that's a really kind of nuanced question, because if you have a clot in your leg and stop blood thinners and get another clot, it tends to reoccur as a clot in the leg. Whereas if you have a clot in the lungs, you stop your blood thinners and get another clot, it can quite often be as a clot in the lungs. So these are real nuances that you need to discuss in clinic. And then, of course, the individual person can have risks for having a clot. And I've just put some of those at the bottom of the slide up about age, weight, so on and so forth. And they're very individual factors that patients should pick apart with their specialists in clinic, and may help determine their risk of a further clot if they stop blood thinners. So you can see it's a really nuanced conversation and very individualized for the clot the person had and who that person is and what their values are. And the typical situation is someone that's in the commandos or the armed forces, and if they have a clot, really staying on blood thinners could end their career. So they're important decisions to get right. Next slide, please. So, but bleeding risk is the other sort of side of the seesaw, because if patients carry on blood thinners, there is a bleeding risk, and bleeding can be serious, and actually there is some evidence it can be more serious than having another clot. But that's difficult sometimes for people to take on board, because they may only have experienced the seriousness of a clot and not that of a bleeding complication. And depending on who the patient is and very individual factors, the risks of serious bleeding every year can be very low to less than 1%, but can be quite substantial to more than 5%. And the key to that is realizing that the risks of clot and bleeding can be fairly evenly matched. So they're very finely balanced decisions. And I'd say a big thing that we historically may not have tackled that well for women is heavy menstrual bleeding. And this is really common on the new anticoagulants, what we call the direct oral anticoagulants, with up to 25 to 50% of women reporting heavy menstrual bleeding. This can be quite challenging to manage, but there are lots of good treatments, and it's really critical that women with heavy periods don't suffer in silence and talk to their specialists about it to get a strategy that works for them. And I've touched on occupation at the bottom and decision making. So next slide, please. This is the other thing I'll just touch on. These are all the anticoagulants or preventative medications for clots that I could think of that we use in our clinics in Addenbrooke's. And so aspirin is recommended by NICE to prevent clots for long-term use. But there's also low dose of rivaroxaban and apixaban, or half dose, some people call it. And then there are full doses of these, and all of these have pros and cons. So that can also be debated in clinic for that kind of nuanced choice of what people want. And they're all very individual in how they work, and their pluses and minuses. So next slide, please. And this is a key question, is there a reversal agent? So if you bleed, can the medication be reversed? Next slide, please. So breathlessness after PE is a really common query, and a 3-month point is a great time to review that. 30% of patients have this thing called post-PE syndrome, which is ongoing symptoms of breathlessness. But we don't think, we don't really understand why. It doesn't appear to be serious or physiologically explained with tests, maybe due to deconditioning, but it's a really important time to get that reviewed. And I think Shaun's case is really good because it actually highlighted he had another medical issue that needed dealing with, rather than just say, oh, it's post-PE syndrome. So careful review of that's needed. And a very small percentage of people have long-term problems from clots called chronic thromboembolic pulmonary hypertension, but medics often call it CTEPH, which needs really specialist care. And as Shaun alluded to, some patients referred to Papworth in Cambridge for review of that. And that's where there's long-term scarring in the lungs from the clots. And the final question is, patients often ask, do I still have clots in my lungs and do I need another scan? I'm not going to answer that because that's a complex answer, but that's a really important question that patients ask their doctor. Next slide, please. And finally, the swollen leg after a DVT. This is really common. It causes so much anxiety and also representation to our service. And distress. There's this concept of residual vein occlusion, which is scarring in the vein caused by the clot. And it's really important patients get a chance to discuss this. We call this syndrome post-thrombotic syndrome. It occurs in around 50% of patients after DVT. And I think it's often overlooked, but the 3-month point is a really good time to discuss what this is, what can be done about it. And I've put some options for what can be done about post-thrombotic syndrome at the bottom of the slide, and patients can, well, you can discuss whether that's which of these are options or appropriate for you with your specialist. Next slide, please. So there's loads to get through. Our clinic appointments in Cambridge are 20 minutes, so patients may need more appointments. And also time and space to weigh up the options. I think deciding on lifelong anticoagulation, if you're dead set what you know you want to do, that's easy, but often patients need like a cooling off period, like buying an expensive car. You would go back, a couple of weeks later. And finally, there's Thrombosis UK, and I've really emphasised the importance of the website because it deals with so many of the questions that patients want to ask about lifestyle, what about clots, in a patient-centred way. And then at the clinic appointment, that can save a bit of time because there's so much general information available there. So I'd strongly encourage looking at that website. Thank you.
Thank you very much, Will. That was really informative, and certainly for me, you raised the discussion around the risks and the benefits, and also the individuality of what's important to the person, the patient sat there. And I'm sure that resonated with many people watching today. And we'll come back to that. I can see some questions have been submitted, but we'll come back to those at the end if that's okay. Thank you. Okay, for our next speaker, I am delighted to introduce Emma G. Emma is a nurse consultant in thrombosis and anticoagulation at King's College Hospital, London. And today Emma's going to talk about accessing information about blood clots, where you can go and also how you can select what's right for you and what's reliable. So again, over to you, Emma. Thank you.
Thank you, Jo, and thanks for inviting me to talk today. We know from the research done into the patient experience and the psychological impact of thrombosis that patient information is one of the most important things to get right, and one of the most important things in helping you cope with having a blood clot. So today I'm just going to give you some ideas. It probably won't be exhaustive, but hopefully just give you some ideas about how you can access good quality information. So first of all, just to take a quick look at what we are told as healthcare professionals we need to tell you about blood clots. So this is the national guidance that the National Institute of Health and Care Excellence tell us that we should be talking to you about. So we should give you written information when you get a clot about signs and symptoms and possible complications of thrombosis and treatment as well. We need to let you know the contact details of a healthcare professional or team. And I think that's really important. And if you don't get offered that, then please do ask for that. Because as we've already mentioned in the excellent talks that we've had today, there is a lot to take on board, particularly if you're not expecting a diagnosis of thrombosis. I think it can be a big shock. And the information that you're given verbally and in writing at the time may not cover everything that comes to mind, particularly later on, and once you've had time to digest that diagnosis. So it's really important that you have a point of contact. You don't have to wait until your next appointment in the clinic. You've got a point of contact, a phone number, email address, whatever suits you best, so that you can contact people with questions as they arise. We've also got some guidance from the British Thoracic Society, recent guidance, and they talk from a perspective of looking after patients that have had a pulmonary embolism, a blood clot in their lungs, and making sure that they're safety netted with the correct verbal and written information. And again, a point of contact is really important. So NICE go into a bit more detail when we look at the information that you need around having an anticoagulant. And Tina has already really nicely outlined the risks involved and some of the things that you need to take into consideration. So we do spend a fair bit of time going through this. It's not like other medications, although it is vitally important for treatment of your thrombosis. It does come at the cost of slightly increased risk of bleeding. So we will spend time telling you about that. But also I think we have an awareness that, like I say, when you're just diagnosed with a clot, maybe as an outpatient or whilst you're in hospital, I think that your mind is trying to process a lot more than being able to concentrate just on some of the nuances of your new medication that you're trying to take. So that's why, as Tina said, we will always give you written information to back that up as well. So NICE goes on to say that we need to give you the oral anticoagulant card that Tina spoke about, and advise you to carry that card at all times. Paramedics, other healthcare professionals know about that yellow card. They're trained to look out for it, so that's really important. And also a fairly new addition is to make you aware that heparins, so some of you may have had treatment with low membrane heparin injection, often the one given in your stomach. They're of animal origin, and that Apixaban, Rivaroxaban contain lactose as well from cow's milk. So looking a little bit more generally at the wider healthcare context, the NHS and government guidance contain these two pieces of literature. So one is about accessible information standards, which is really designed to cover patients that have a disability or some sort of impairment or sensory loss that might mean that getting and understanding information is more difficult for them. And on the right here, you've got some, this again is new actually, this was just published during COVID, and I think it was very much needed in a time where we were unable to see patients face to face a lot of the time. Just a reminder of those quality standards in making sure that patients have the correct information and that we communicate very clearly with you. Because time and time again, and I'm sure as patients who have experienced this, as healthcare professionals, we've all experienced where communication breakdown happens, and it leads to dissatisfaction, usually on both sides. So we talked a little bit about what the healthcare regulators think that you need to know. But we know that as well as being concerned about your safety, which is I think a lot of what the NICE guidance covers, there are lots of lifestyle issues and questions that you might have. And I won't go through all of those because a lot of those have already been covered. But these are the sorts of things that you may not think of these initially when you're diagnosed, but certainly later on when you get home and reality starts to hit, these are the types of things that you may well be thinking about. We put a lot of these sorts of questions in our own patient information leaflet here at King's. They're the frequently asked questions, the things that you often need to know about. Now, once you've exhausted your information literature given to you by your hospital or healthcare setting, you then may have some unanswered questions and turn to Dr. Google. If you do, you're not alone. Nearly 2/3 of the British public have used Dr. Google. And I think that I'm sure everybody is well aware, though, that it can be a bit of a rabbit warren. There's a lot of fantastic information out there, but we will go through a few steps to guide you on what information is reliable and how to determine if it's reliable or not. The other thing to note as well is I've noticed when I've been Dr. Googling is that the information given to you when you put in your search term won't always be very specific. So you may happily click on something only to realise actually it's not quite the same diagnosis as you've got. So just to be very careful about what you ask Dr. Google, other search engines are available, and just to be very aware of what results it's giving you and whether that is specific and relevant to you. So how can you tell if sources are reliable? And I'm not just talking about the internet here, but I'm aware that for most of us that's the most easy and accessible way of getting information. So first of all, look at the source. Who wrote the information that you're looking at, and what are their credentials? Are they knowledgeable in the field? Are they somebody with a recent knowledge in that field? And also what the motivation is behind them writing that. So is it sponsored, say by a drug company or another sort of corporate company? Is the person coming from a place of bias? So is their information going to be very fairly written in a way that will be genuinely helpful for you? A lot of healthcare information is what we call peer-reviewed. So it isn't just somebody writing down their opinion and popping it online. It will be checked by somebody else who also has the appropriate credentials to say whether that information is fair, unbiased, and represents current knowledge. So look at when it was published. That's very important. It may well be that it's out of date by now. And does it use evidence? So again, in the healthcare arena, much of what you find online will be referenced. So there will be a reference. You can then go and look at that reference and determine whether actually that information has been taken accurately from that reference, and also whether that reference is relevant to you. So is it something that's fairly recent and has sort of broad scope? Avoid non-regulated chat rooms. So I think that we've sort of already touched on the fact that it's really, really nice to seek out other people who have gone through the same thing as you. And Thrombosis UK is a wonderful resource for using to get in contact with other people. It's really beneficial, and some of the research that's been done on the psychological impact supports that. But just be aware that if you do visit a non-regulated chat room, then what people tell you are going to be very, very nuanced and specific and not necessarily going to be relevant to you. Often it's quite easy and quick to find American guidance. There's a lot of guidance from some of the big American healthcare companies like Cleveland Clinic and Mayo Clinic, and those sorts of information are fairly easy to find. It's definitely worth having a look at, but just be aware that the guidelines in the UK often vary slightly to those in America, and also the treatments and drugs that are available may vary. I came across the Patient Information Forum, which was set up by the King's Fund. It's a not-for-profit organisation, and this Patient Information Forum was set up many years ago now, and there are over 1,000 members, and their emphasis is very much on ensuring that information given to patients is reliable. And fairly recently, they've come up with a new quality standard called the PIF tick, Patient Information Forum tick. And there are 10 criteria that organisations have to meet in order to gain the PIF tick, and it's assessed by a board at the Patient Information Forum. So I think that's fairly new, but going forwards, that will be a really good mark of quality for you to look out for. So just considerations when you are looking online. The internet cannot know you. It cannot know your individual situation. It can't know exactly how to interpret the question that perhaps you've asked it. Information may not be up to date. That doesn't mean it isn't relevant. Sometimes in healthcare, research studies are performed many, many years ago, and we still use those because we haven't necessarily been able to perform any studies since then that have actually challenged that information. No substitute for your own healthcare team. Tina said, go to your appointment with questions, and I wholeheartedly support that. And Shaun said something which really struck a chord with me. He said that he wanted to ask about things that kept him awake at night, and we certainly want to hear about those, even if you think it's a bit ridiculous, or you should know the answer to that question, or even that we are not going to be able to answer that question for you. If it matters to you, then we do want to hear about it in the consultations. And it may well be that we can completely put your mind at rest, or give you the information to take forward so that you can start your recovery. And also be aware that information online, it's not always accuracy checked. So there's a chance that it's inaccurate. There is a chance that it's biased. Maybe someone's got a different agenda or trying to sell something. But just to give you some starting points, some reliable sources to look at, obviously the NHS website. It used to be NHS Choices, now it's nhs.uk. Thrombosis UK obviously goes without saying, and other charities, particularly with the org.uk websites. UK hospital websites, when I did a quick search, I found that quite a lot have their own VTE, so DVT, PE information leaflets online. And you might well find that looking at several of them gives you quite a nice overview, and as they may each have a slightly different focus. You can always visit your local pharmacist as well if you're having trouble getting in contact with anybody else, or you just happen to be passing. They're a wealth of information, particularly around medications, but sometimes about your healthcare conditions as well. It's always worth asking. Obviously, they'll tell you if they can't help you, and they will direct you in where to get more help. Obviously, your GP is going to be a great source of information and support, and your thrombosis team. And just to re-emphasise the point that you need to have a phone number or an email to direct queries after your consultation, as I said before. And Thrombosis UK have also got a really nice page on their website giving an overview of approved health apps, some of which look really good and really interesting. I must admit I'm not experienced in using any myself, but some of those I thought looked very, very helpful. So that's another potential source of information. So many thanks for listening today, and I look forward to hearing some of your questions in the panel discussion.
Thank you so much, Emma. That was really, really informative. Thank you. We've already got questions coming through, so I think I've already asked a couple, so I will go to those that have come through. And this is, when Amanda's asked, how often should follow-up VTE consultations occur for those on blood thinners for life? And should they be with your GP or within a hospital setting, or can it vary? Will, perhaps if we go to you first.
Yeah, so it's a good question because it's a little bit variable upon the patient and how many unresolved questions or medical needs they've got. The reality in Cambridge is that we discharge the vast majority of patients back to primary care, even if they're on anticoagulation, and they are followed up between 3 to 12 monthly with the GP surgery. And so it's a little dependent. We do have the next need that
Will, can I ask you to just repeat that section? I think your internet just dropped for a moment.
Yeah, so we have a few patients who stay long in the medical sort of consultant-led clinic who are to follow 12 monthly with the GP.
I think we best pause. I wonder, while the internet just settles itself out, it just dipped again. So I think if I was recapping what you were saying, Will, or maybe Tina, you might be able to also help because I know you're at the same place.
Can you hear me now?
Yes, yeah.
Yep. So a few patients belong to the curve, others patients followed up 12 months to therapies.
I think we're going to have to pause there. Tina, are you able to explain? In obviously this is a little bit specific to where you're based, but in general, how does the follow-up work or should work?
So normally, if you've had a blood clot in Cambridge, you'll have most patients will have a thrombophilia, a follow-up appointment after 12 weeks, around 12 weeks after their initial diagnosis. And then depending on that, they may well get another appointment, another 6 months after that. And then I think most of the time once they're on long-term anticoagulant and they're established on that and they're happy, then it'll go back to the GP, and the GP will do regular follow-ups. And through there, I think is how it works with the follow-ups here in Cambridge.
Thank you. Thank you.
Can I just add something, Jo? Just very
please.
briefly. It works in a similar way actually at King's, but what I wanted to add there was that if you're on a long-term anticoagulant, you should have an annual review. And often that will be done in primary care by your GP. But if you are not contacted by your GP, then that's something you can get in contact with them about and just say, look, you know, any chance we could have a consultation just to discuss how things are going. Even if everything's going well, it's always a good idea just to make sure that there isn't an alternative, or that actually to make sure that you should still be on anticoagulation.
Thank you. Because certainly, Anya, I think you'll say the same. We do hear sometimes from patients who have not had any follow-up or not been guided as to when a follow-up will come. And so if they've just been diagnosed and 2 to 3 weeks later, they still haven't received anything, would you recommend they contact their GP or go or contact back into the service where they were diagnosed to say, what should I be expecting? How do I take this forward? Am I getting a discharge letter or something? What would the actions be that they'd need to take?
Was that to me, Jo? Sorry.
Yeah, sorry, Emma.
Yeah.
We'll go back to
No, absolutely. I think it's a little bit difficult to speak for the whole country because anticoagulation services are set up differently in different areas. So some patients will be diagnosed with a clot and go straight to primary care. And when we say primary care, we mean your GP, your local health centre. Others will remain under the care of the hospital. But yes, you should be followed up after having a blood clot within the next few weeks to make sure that you're getting on okay with the treatment and that your symptoms are starting to settle. And again, to answer any questions that you've got. And if you don't receive any follow-up, then I think the first port of call, generally speaking, is going to be your GP, who would then be able to refer you to the appropriate service.
Thank you. Well, we have a question which is quite specific, but I'm going to come to you with it because I think it's about deciding why you might continue to be on blood thinners for life. So you spoke about clearly heavily provoked, mildly provoked and unprovoked, and it's around somebody who has had a blood clot following a C-section, but then also found to have factor V Leiden. So what sort of discussions should they have with their consultant around those two risk factors to decide their long-term anticoagulation care?
Yeah, so can you hear me again now, Jo?
Yes, we can.
I don't want to specifically answer this question because that's very personal for this lady's inquiry. I think that the question is a really brilliant one, and I would go back to a haematologist and specifically ask them my risk of a clot after a caesarean section and how factor V Leiden, and there are two sorts of factor V Leiden, whether you carry one of the genes or whether you carry both, and I would that's another sort of factor, and I'd really carefully put it to my specialist about the interaction between those two. I think it's really key that everyone asks, what's my risk of another clot in the future if I stop blood thinners, and if I get another clot, where's it likely to be? Because a clot occurring around your ankle, it's not nice, but it's not really dangerous in the way that a big clot in the middle of your lungs is. And I just think they're such critical points for people to tease out.
Thank you, Will. Thank you. We have some questions as well about, you alluded to treatments that you can have if you do suffer with heavy periods. Would your GP be an ideal person to go there to discuss what exactly you're on and what they could consider to help with that? Or would you look to go back to the haematologist?
It's a bit of a multidisciplinary thing because I'm probably a bit more willing to get involved in managing heavy menstrual bleeding than I'm probably a bit more involved than other haematologists, I suppose. Your GP is a really good port of call, and then they've really got two other sources of help, which is your haematology service, because your haematology service can review your anticoagulation. There are differences in anticoagulation which can affect heavy menstrual bleeding. And the second thing is the gynecology service. And the gynecology service can offer tablets, and there are different sorts of tablets to help with heavy menstrual bleeding. Hormonal therapies, the Mirena coil, which is a progesterone coil. It does not increase clot risk, and it reduces the risk, it reduces 90% of people that have it don't have heavy menstrual bleeding. It's or periods. It's a miracle in that sense. And occasionally surgery, heavy menstrual bleeding. So gynecology and haematology are very helpful. But GPs are really experienced, and many are able to competently manage this problem.
Thank you. Shaun, can I go to you, because you raised a huge number of appointments you'd had since your diagnosis, and those were also across multiple different medical disciplines. If you were given somebody perhaps 3 tips, what helped you share information and feel that when you left those consultations, whether they were with your GP, anticoagulant nurse, or a consultant in respiratory or elsewhere, that you felt you would come away with more understanding or more help? What tips would you give that really you found beneficial?
Well, first of all, it just goes back to something that I said earlier, and also Emma reinforced, is what are the questions that are keeping me awake at night? And did I get the chance to voice those questions and have them answered? So that's the first thing. I think secondly, from a patient's point of view, is really trying to understand where you're at in that journey, and also be willing to listen to what some of our medical colleagues and some of the things that are shared with us. So I've only got 2 tips. I'm sorry, I've got a third, but it's fundamentally around this issue about really being clear about the questions. And if you walk out the door having had those questions answered, and can I say some of those answers are uncomfortable, but they're still being answered, and it helps me then make a decision. There's times I've walked out of consultations with tears rolling down my face, most my wife and I, but he answered me questions because I asked. It was one of the questions that kept us awake at night.
Thank you so much. I think you summed up brilliantly. We've actually gone over our time, but a very, very powerful, informative session. I am so grateful to you all. I can see, and I know you can from the chats coming in, people have already thanked you or are thanking you. We have recorded this. It will be available on the Thrombosis UK website within the next 24 hours. And I think as we go forward, hundreds and hundreds of more people will benefit from the information you've helped to share today. So thank you so very, very much. And for now, goodbye. Thank you.